Good morning, myself Ahilan. I am an assistant professor in orthopedics. Today we are going to see shoulder examination. We are going to proceed with the question and what are all the inferences. So before going to that, we need to know the normal anatomy. What is the osteology? What shoulder joint is consistent? So shoulder joint is also called a glenohumeral joint because it is happened between the articulation of the humeral side and the glenoid. Glenoid cavity is the part of scapula. So it contains glenohumeral joint, acromioclavicular joint. Acromion also is a part of scapula, sternoclavicular joint, and scapulothoracic joint. These four consist of the total shoulder joint. So the anatomy of the glenohumeral joint is very important for us because those are the things which make us to move the shoulder. So there are static stabilizers and dynamic stabilizers. So the dynamic stabilizers are the ligaments. There are three glenohumeral ligaments that provide antero-inferior stability and in different positions. And superior glenohumeral ligaments provide stability to the glenohumeral joint in the 0-degree adduction and middle glenohumeral ligaments and 45-degree of abduction. And inferior glenohumeral ligaments has two bands. It has the anterior and posterior bands, which acts as a hammer and acts as a support and acts as a head inferiorly during abduction beyond 90 degree. And labrum. Labrum is a form of a cartilage. It is called a glenoid labrum. It is a circumferential fibrocartilaginous structures which form around the glenoid cavity. It deepens the glenoid cavity and creates a choke block effect for the stability. Since glenoid is a very shallow structure, this labrum will add an additional support to prevent shoulder to humerus, head of the humerus to dislocate from it. Capsule is the major stabilizer of the joint and it is a tight structure. And it extends from the anatomical neck of the humerus to the border and rim of the glenoid fossa. And the main stabilizers of the shoulder joint are the rotator cuff muscles. These rotator cuff muscles are the four muscles are there. These present around the shoulder joint. This includes supraspinatus, infraspinatus, teres minor, and subscapularis. This supraspinatus, teres minor, and infraspinatus will attach to the greater tuberosity, but the subscapularis will attach to the lesser tuberosity. But the one main problem is there will be a defect at the inferior part. That's called between the infraspinatus and subscapularis. This is called the rotator implant, and this is because there's some lag in the cord because of the laxity of the ligament. There are more chance of the shoulder to get dislocated during the from the rotator impact. And the bony static part, static stabilizers of the glenoid and the head of the humerus. Glenoid is a pear-shaped part of the scapula that articulates with the head of the humerus. The main problem is like the hip joint. Hip joint have the acetabulum is more deep in shape. So the head of the femur will go deeply attached to the acetabulum. But the glenoid is not like acetabulum. It is very shallow, and the humerus will partly move around the glenoid, shallow glenoid. So there is a dislocation of the shoulder joint is more commonly than any other like hip or ankle joint like. So movements of the glenohumeral joint includes abduction. The abduction is around 0 to 180 degree, and forward flexion is about 120 degree, and extension is about the 30 to 40 degree, and some internal rotation and external rotation. Both are around 0 to 35 to 40 degree. The vascularity of the head of the humerus is very important because it is supplied by the anterior and posterior circumflex humeral muscles. This anterior and posterior circumflex humeral muscles are the part of the third part of the subclavian artery. You all should know the subclavian artery has three parts. So when we see this is the forward flexion. This is the extension of the shoulder joint. This is abduction. This is adduction. This is internal rotation and this is external rotation. Usually the internal rotation The patient should touch hand up to the middle of the back. But sometimes if there is any restriction, you should not able to touch the middle of the back. Sometimes the patient can touch the parascum region. Sometimes he can touch up to the hip joint level. So when you see this image, this is the glenoid cavity. This is a very shallow structure. And you see this is called the axillary pouch. This is superior glenohumeral ligament, middle glenohumeral ligament, and inferior glenohumeral ligament. This is of anterior and posterior glenohumeral ligament. So this is the colloquial process anteriorly. This is the spine of the scapula. So when you see the rotator cuff muscles, this is greater tuberosity of the humerus. This is supraspinatus, infraspinatus, teres minor, and posteriorly subscapularis will attach at the lesser tuberosity. So all these three muscles will be anterior, subscapularis will be posterior. And you see there is a defect of the inferior. In inferior there will be no muscles. So we should know the origin and the insertion of those some muscles, the at least the rotator cuff and shoulder muscles, because that is very important for us to examine. So this deltoid consists of the insertion of the deltoid is in the upper third of the shaft of the humerus. And the main supply, nerve supply of the deltoid is the axillary nerve. So when the axillary nerve, the main action of the deltoid is abduction of the shoulder joint, mainly from 15 degree to 90 degree. The initial abduction from the 0 to 15 degree will done by the supraspinatus muscle. And from 50 to 90 degree, it is done by the deltoid. And more than 90 degree up to the head, overhead, it is done by the upper thoracic muscles and trapezius muscle. So if there is a axillary nerve injury or deltoid muscle injury, the abduction up to 90 degree will be lost, and the axillary nerve will supply the sensation to the this lower part of arm region, proximal arm. This is called regiment badge sign because in military there is a badge called regiment. They will apply here. So this lower part of the arm, the patient proximal arm, patient will have no sensation. So clearly see this is here. So this is if there is an axillary nerve injury, patient have loss of sensation or reduced the sensation over this region. So you can know the is called resonant vaccine and the axillary nerve will get injured. And the next muscle is supraspinatus. This supraspinatus muscle will attach to the greater tuberosity. And the origin of the supraspinatus muscle is from the suprascapular fossa. In scapula, we have two fossa the posterior. One is the suprascapular region and the infrascapular region, divided by the spine of the scapula. So from the suprascapular region, the supraspinatus muscle will arise inserted to the greater tuberosity. The infraspinatus region will arise from the infraspinous fossa, infrascapular fossa, and it's attached to the greater tuberosity. And the teres minor will arise from the dorsoventral surface of the scapula and attached to the greater tuberosity. So these three muscles will attach to the greater tuberosity. The nerve supply of the supra and infraspinatus will be the suprascapular nerve. And the teres minor is axial nerve. So the axillary nerve will supply two muscles, which is deltoid and teres minor. Suprascapular nerve will supply supraspinatus and infraspinatus. So you should know the root value of the supraspinatus. It is from the brachial plexus, root of the brachial plexus, or it will arise from the trunk of the brachial plexus. So you should know the brachial plexus thoroughly. What are the cords? What are the divisions? What are the nerves arising from the root? The nerves arising from the roots are long thoracic nerve. The nerves arising from the trunk are suprascapular nerve and nerve to subscapularis. So, as I told, the action of supraspinatus is abduction, but it is the initial abduction, 0 to 15 degree of abduction. And the infraspinatus and the teres minor action is external rotation. Then the subscapularis. The subscapularis, as you know, It originates from the ventral surface of the scapula and is inserted into the lesser tuberosity. As we saw in this image, this is the subscapular insertion into the lesser tuberosity. So this action of the subscapular is internal rotation. The nerve supply is upper and lower subscapular nerve itself. This upper and lower subscapular nerve is also arise from the root of the brachial plexus, or sometimes it arises from the trunk of the brachial plexus. The next muscle is the latissimus dorsi. This last latissimus dorsi is very important because this is the very big and major muscles at the back. So this latissimus dorsi will arise from the posterior spinal line, transverse process of upper thoracic and lumbar vertebra, and it lumbar fascia, and it attached to the intertubercular groove of the humerus. So you should know the from as you from the first year of MBS from anatomy, you also you read the one of the mnemonic, the lady between the two major. So the two major is the humerus is teres major and pectoralis major, and the intertubercular groove is the lady is the latissimus dorsi. So the latissimus dorsi is present between the intertubercular groove, and the the floor, the latissimus dorsi is the floor of the intertubercular groove. But they will ask what is the content of the intertubercular groove. The content of the intertubercular groove is the long head of the biceps tendon. So you should not confuse between these two. The floor of the intertubercular groove is the latissimus dorsi, but the content of the intertubercular groove is the long head of the biceps. And the tubercular, this has the two majors in between the teres major and pectoralis major. That has the tubercular groove. The medial in the medial aspect of the humerus, the teres major will attach. The pectoralis major will attach the lateral aspect of the tubercular. And the latissimus dorsi now supplies the thoracodorsal nerve. So the action of the latissimus dorsi is the extensor. It abducts the shoulder joint and it internally rotates the shoulder joint. So the next muscle is the trapezius. This trapezius has the posterior insertion at the posterior border of the lateral one third of the clavicle and the upper third of the scapula and the spine of the scapula and also the acromion process. So this trapezius is supplied by the spinal accessory nerve. So if you want to check the spinal accessory nerve, you ask the patient to shrug the shoulder, and patient can't shrug the shoulder. So that's the defect of this trapezius. So this action of the trapezius is the rotation of the shoulder, retraction, elevation, and depression of the scapula. Then the muscle is serratus anterior. The serratus anterior is origin from the ribs 1 to rib 9 on the lateral aspect, and it's attached to the costal aspect of medial margin of the scapula. So it runs from the forward anteriorly to the posteriorly, and this is supplied by the long thoracic nerve. And the main action of the serratus anterior is the protracts the scapula and his upward rotation. So the protraction of scapula is this coming forward. This is retraction. If you are coming forward and taking something, this is the protraction. So your scapula is like this, it will go and protract it like this. So you all know from the anatomy, this is very famous, very important question. What is the nerve injury if happened long thoracic nerve? This is the long thoracic nerve, or the other is called long thoracic nerve of bell. What you will see is the clinical defect beginning of the scapula, because in the side long thoracic nerve is affected, that side the serratus muscle anterior action will be lost. So the when the action is lost, that time the scapula can't able to protect. So how will you test the muscle? You ask the patient to push the valve by both the hand. So which side the nerve injury is that side you can see the scapula more prominent than the opposite side. Then the major muscle is the pectoralis muscle. Pectoralis major is the anterior muscle from the chest. So the origin of the pectoralis major is the sternum, xiphisternum, and some sternoclavicular and sternocostal joint, and some middle third and medial third of clavicle. And the fibers will go laterally and it attaches to the lateral tubercle of the humerus. The medial tubercle of the humerus, which muscle will attach which major? Teres major. Okay. Remember the name, lady between the two major. See, it's to the insertion of the pectoralis major is lateral lip of bicipital lobe. So the teres major is medial lip of bicipital lobe. So the pectoralis major, the nerve supplies the lateral and the medial pectoral nerve. This is very important. And there is another muscle called pectoralis minor, which is supplied by the only the medial pectoral nerve. So the action of pectoralis major, since it's the anterior chest muscle, you remember when people who are going to gym, they'll put the chest. So the chest mission hub will put like this. So this is the action of pectoralis major. So what are the action you see? Internal rotation of the shoulder joint, abduction of the shoulder joint, and there is a flexion of the humerus, forward flexion. So this is the action of the pectoralis major. So these are the main muscles around the shoulder joint in front and the back of the humerus, which helps in movement of the shoulder joint and proximal humerus. And these are also act as stabilizers. So now we'll see what are the common conditions which affect the shoulder joint before we proceed to the examination. So in any joint examination, any joint, you need to have the five conditions as a etiological factor: idiopathic, degenerative, traumatic, congenital, inflammatory, infections, then neoplastic, some neurological condition. So these 6 to 7 etiology you need to exclude from your history and examination. Okay, this is common for all the joints. So if you follow this order, you can't miss any of it, and you will come to know the provisional diagnosis from what happened. So idiopathic means like primary frozen shoulder, so shoulder hand syndrome. And degenerative conditions you can see in the old age patients like rotator cuff tendinitis, rotator cuff tendinopathy, calcific tendinitis, and previous rotator cuff tear, which change into the degenerative glenohumeral arthritis, acromioclavicular arthritis, and rotator cuff arthropathy. These are the some degenerative conditions. And traumatic means like dislocation of the humerus, proximal humerus fractures, associated brachial plexus injury, or rotator cuff tear. So because of the trauma, the shoulder joint movements will get affected. And congenital call some syndrome called Sprengel shoulder, Klippel-Feller syndrome. These are the some rare conditions of the shoulder joint. And infection, tuberculosis of the shoulder joint, and septic arthritis. See, in India, in this tuberculosis is endemic. So, whatever the condition, whatever the joint pain, you should not miss out tuberculosis. You should always have the tuberculosis as a differential diagnosis or a secondary diagnosis, or by investigation, you should always rule out the tuberculosis, whatever the joint. So, the tuberculosis of the shoulder joint is called carries Zika, and septic arthritis also you should rule. And the inflammatory conditions called rheumatoid arthritis, gout, pseudo gout, and arthritis related to inflammatory bowel disease. These are the conditions of inflammatory conditions. And some neurological conditions like Charcot joint, shoulder brachial plexus injury. And the neoplastic conditions like benign and malignant tumors also you should not miss. Even though it is rare, you should not miss that to ask or examine, and you should keep it as a last option in the back of your mind. So the common like neoplastic condition, the benign tumors of the shoulder proximal humerus will be the simple bone cyst or aneurysmal bone cyst. So these are the condition patient will be asymptomatic, and you will find when for any other reason you examine the patient or you take the shoulder X-ray. This might be the incidental finding. And some malignant tumor includes the primary malignant tumor. The most common primary malignant tumor of the bone is the multiple myeloma. The second most common malignant primary bone tumor is osteosarcoma. And sometimes you can see the metastasis to the bone also. So we should know what are the common tumors is metastasis to the bone, which includes thyroid, breast, lungs, pancreas, and sometimes stomach and kidney too. So these are the things we saw now. What are the age groups? What are the conditions it suffer? So how will the patient present with the chief complaints? Patient may come with the pain, patient may come with the difficulty in the shoulder movements, or sometimes the overhead activity, or some reaching the back, or some combing hair, or patient will be like unable to do daily day-to-day activities, cannot throw the ball. Sometimes patient will have catching, blocking, sometimes swelling, and limitation of the daily activities. So after finishing the history, after you rule out the etiologies, when you come to the examination, you should always expose the patient. You should ask the patient to remove the shoe because you need to compare the shoulder with the opposite side shoulder. You should always examine the other side shoulder to know whether this is normal. So you need to remove the patient's shoulder. If it's a female patient, you need to have a sister nearby or a chaperone nearby. So first we should inspection. From the inspection, we need to inspect the patient from the front, from the side, from the back. These three are very important. You should not inspect from the one side and you should not tell me. Because in inspection, you need to first see the posture, how the patient is standing. In what posture patient is standing, that is very important. Whether this both shoulder level are at the same level, or whether any side shoulder is drooping is there or not. And you should know that any muscle wasting is there from the front, like supraclavicular region, infraclavicular region, from the side, the deltoid region, and from posteriorly, any this thing, any muscle wasting is there or not. You should always see. So this is a condition where you can see the elevation of the shoulder joint of the left side, or you can see the depression of the shoulder on the right side. So this you should see in the inspection from the front. The general posture and attitude, how the patient is keeping the shoulder joint, like flex or extended leg or normal attitude. Normal attitude is needed when the patient can keep his arms and forearms on the side of the body. This is needed. And you should also see the shoulder contact and any like swelling is there, any redness, any trauma, any like previous scars, any sinuses, any discharges, or any visible pulsations, or any color changes, whether it is tense or any like lipodermatosclerosis, something like that, you should see on the shoulder joint. Okay, that is the main inspection. And you should inspect from the front, should inspect from the side, inspect from the back. And posteriorly, you very importantly, you should see the scapula, the level of the scapula. You see the north. This is the superior border of the scapula, inferior border of the scapula. Normally, the superior and inferior angle of scapula lie at the level of D2, D3, and inferior will be the T7 and T8. The distance between the medial border of the scapula from the spine of the scapula should be equidistant. See, this is the medial border of medial border. This is spinous process. This is the medial border of scapula. We should measure this medial border of scapula with the spine distance, and it should be same from the both the sides. Or if any disparity is there, that means like something there is a problem with the shoulder. So you see this side, the right shoulder, the left side shoulder is elevated, and the distance between the midline to medial border of shoulder, right side is more and left side is less. And this is the condition called springle shoulder. The left side scapula is higher and smaller in comparison to the right side. You see there is a bump here, the shoulder, because it is small and its scapula is higher than other. This is springle shoulder. Springle shoulder is a short notes, okay? So read about it. Next class you will see about it. So as I told, shape of the scapula and more importantly, winging of scapula. This is very important. So what I told, the scapula, meaning of scapula, how we should check. As I told, we should push the wall against, we should try to push the wall against the resistance. And from back, the examiner should inspect from the back. And if there is any more protrusion of the scapula, and you can see from one side, it is not visible. On one side, the scapula is more prominent. Which side is more prominent? That side, the scapula is affected. And next, we go to the palpation. So these are the inspectory findings. You should check the front, sides, and the back. Next, palpation. First thing, as for every joint, we should check for the warmth. So warmth, you should check for the anterior, this anterior part, check for the lateral, and check for the posterior part, and you should compare it to the opposite side, opposite side shoulder. So after the warmth, you should go for the tenderness. The tenderness, we should check there is some systemic way of checking the tenderness. So you should not miss any of the point. You see from the anterior, we should check the clavicle. We should come from the clavicle, medial end of clavicle, middle part of clavicle, lateral end of clavicle, and three is the acromioclavicular joint. Four is the coracoid process, and come down. Five is the anterior joint line. Six is the humeral head, the lesser tuberosity. Seven is the bicipital groove, and then from lateral, eight is the greater tuberosity. Nine come to superior acromion, and then 10. You see, what is the spine of the scapula? 11 is the medial border of the scapula. 12 is the inferior border of the scapula. 13 is the medial border of scapula. Okay. And 14, you can complete the around the scapula. So this is how your examination palpation of the shoulder joint. From 1 to 3 anterior, you come superior, lateral, and from lateral, you go and come to posterior and inferior. So when doing this systematically, you won't miss the any part. Okay. Next, what is Baton score? Baton score is very important. Okay, because sometimes there is generalized laxity. You can see in some patients, some people, in all other part. Generally, it's a normal variant. So you should know the Baton score because sometimes when the patient is having more movement of any joint, you should not think that is abnormal. Some patients normally they will have hyperlaxity. So what you should check? Right side and left side of the thumb. Passive opposition of the flexion aspect of the forearm. So you should flex the thumb. Normally you should not touch the forearm, but in Baton score, if it's a hyperlaxity, the thumb will flex up to the forearm. And second is the little finger. The little finger, we should do the passive dorsiflexion of the metacarpal phalangeal joint. And it should not touch, it should not go beyond 90 degrees. But if there is a hyperextension, hyperlaxity, the little finger will go beyond the 90 degree. So that is possible. And you should check the extension of the elbow. Usually there will be around some 5 degree of extension normally will be there. But this is like hyperextension of beyond 10 degree that indicates hyperlaxity. And knee joint. Knee joint also normally there will be hyperextension of around like 0 to 5 degree. But you see, this is like more of hyperextension is there. This, and there is a forward flexion of spine with knee extended. Okay. So normally when we standing and we touch down, we will touch only the tip of the fingers to the ground. But you see this patient keeping the whole palm at the ground with his knee extended. So these are all the five components you should check in the Baton score. So if the Baton score is more than 8, so that is patient is having the hyperlaxia. Okay. So that is the normal variant. Sometimes patient will have some in general soft tissue disorders and congenital condition. So you should do this Baton score in a general examination before you go to the range of movements. Because if you go to the range of movements before Baton score, you think that is abnormal. So as I told, the range of movements, flexion is 0 to 180 degree, extension is 0 to 60 degree, abduction is 0 to 180 degree, adduction across the body is 0 to 60 degree, external rotation is 0 to 70, and internal rotation is, we should touch the dorsal spine back. So you should, while checking the range of movements, what are the components you see? Is for all the joint. So you should check both active and passive movements of the shoulder joint. Active movement, you ask the patient to do itself actively. And what you should check for how much degree, how much exercise patient can do actively, whether it is associated with pain, whether the pain also only at the initial part Are the pain throughout the movement or pain only at the terminal? And the movement is associated with any crepitus or there is any audible click or crepitus like click like sound while moving. And after the active movement, you should do passively, you should move once. So passive also you should know whether the what are the range of movements. So for every movement, abduction, adduction, flexion, extension, you should ask the group patient actively, and then in passively remaining movement you should check up to 50 degree. In actively, for example, patient can only able to do for 90 degree of abduction. After that, you can't able to do. Passively, you should check. You should go up to 180 degree, and then you should check whether there is any restriction of movement or passively you can be able to do full movement or with any pain associated with any crepitus or any place. Because in osteoarthritis, in this case, in a gliohumeral arthritis, if there is arthritis, the patient will have pain of the whole range of movements and they will be associated with crepitus. Or in case of adhesive capsulitis or frozen shoulder, there will be no passive range of movement itself. Patient will have activity of some degree of abduction or internal extension rotation. Beyond that, even passively also you can't move the jaw. That is like stiff jaw that you can see in the frozen shoulder, like adhesive capsulitis. And there is condition called rotator cuff tear. Patient can't lift the abduction itself. Patient can't lift the arm. For example, 20 to 30 degree only patient can move. But passively, you can move up to full degree. And sometimes that may associated with pain or sometimes may not. So that is some difference you should know about with pain, without pain and other conditions. So measurement. Measurement is very important. You should measure the patient from the anterolateral angle of the acromion to the lateral epicondyle. And forearm is the lateral epicondyle to the tip of the radial process. And special test is very important. You should do the special test for shoulder instability. One test is the apprehension test. In apprehension test, we need to make the patient supine or lie down, and you should stabilize the shoulder joint with one hand and do the external rotation with the other hand. If the patient will apprehend, if there is an instability in the shoulder joint, patient will have the fear like it is going to like dislocate. So that is the apprehension. So if it is there, it's like apprehension positive. And this is the test you can do the supine also. And there is a next test called anterior drawer test. So you should make the patient lie down. You should stabilize the shoulder joint with one hand, and you should pull forward flex the anterior jaw to check whether any abnormal movement is there or not. And this is the posterior jaw. This is also called Silman and Hawkins syndrome. And there is another test called there is a test called impingement. Yeah. See, this is jerk test, and this is otherwise called as Hawkins Kennedy test. What is Hawkins Kennedy test? We should make the shoulder at 90 degree of flexion, elbow at 90 degree of flexion, and we should from the lateral side abduction, we should keep on moving the joint abduction like this. So in doing that, if the patient produce pain at the shoulder joint, it is there is Hawkins Kennedy is positive. This indicates the impingement. Okay, shoulder joints and impingement is there. Impingement can cause various reasons like rotator cuff tear, the impingement of the rotator cuff, or subacromial bursitis, subdeltoid bursitis, and various conditions. And there is another test called Near's impingement test. For Near's impingement, patient should be like forward flex and patient hands should be like internal rotated like this. And passively, we should make the patient hand move like this, forward flex like this. And if the patient exhibits pain while passive forward flexion or the internal rotating of the shoulder, that is called Near's impingement test is positive. And the another test is inferior stability. You can see the sulcus sign. The sulcus sign, when you see the blue arrow, the sulcus, you should hold the patient limb in a adduction and internal rotation and very close to the body, patient's body. And when you do the external rotation of the patient, you can see a small dimple like some small bump. It is called sulcus. It is positive in a inferior instability. And there are four main tests for rotator cuff tears. This rotator cuff tear test is very important. So rotator cuff instability. One is empty can test. In empty can test, the shoulder should be abducted to 30 to 50 degree and internally rotated like this. So it is a empty can. And you should ask the patient to lift the arm against your resistance. And very important, this test should be done bilaterally. And if the patient has pain, is not able to lift, it is the test is positive. And the another test is this is just for internal rotation. So to test the subscapularis muscle. Empty can is for supraspinatus. For subscapularis, you should ask the patient to I will show this. Yes. Yeah. You should ask the patient to do like this. Internally rotate and touch the dorsal spine, and you should give some pressure over the hand and ask the patient to lift off the hand. Normally, patient should able to lift off the hand from the back. But if he is not able to lift off the hand, that is called subscapularis empty canal. Sorry, lift off test is positive. That indicates some subscapularis tendinitis or tear. For the teres minor and infraspinatus, their action is external rotation. So, what test you are going to do? It is called Hornblower test. So, we should ask the patient to sit, abduct the 90 degree and make flexion of the elbow. And you should ask them to do like this, both hands like this. This is called Hornblower. In auto or like bike or like lorry, you would Hornblower like this. So you should make the hand like this. And you should ask the patient whether the patient will produce any pain. So if the patient have any pain, patient not able to hold it like this. Okay, they will drop it. So that is called external rotation lag test. Blue arrow is the direction of the fall of the wrist after clinician view. So this is the external rotation lag test at the 20 degree of abduction is the V and C is the 90 degree of abduction. And blue arrow indicates the patient fall of wrist after the clinician leaves the wrist. Indicates the poster position and the D. This is called practice test. We saw the image D. So it's the same. And the blue arrow indicates the patient posterior push against the resistance. When clinical, suppose the patient elbow on the other hand. Usually, patient should push. If he's not able to push, if he's leave the hand like this external rotation difficult. And you should also check the external rotation by like this. You should ask the patient to adapt the arm towards the shoulder and ask them to do external rotation away and internal rotation. So these are the main tests. This is called Hornblower test. In this Hornblower test, we should compare to the opposite side. We should make the position high like this, but we can't able to do this like this. See, right side he can able to horn blowing like this. Left side he can't able to hold the shoulder joint in a abducted position. External rotation. He left since shoulder is dropping. So that is called horn blowers and positive. High elbow position on the right side compared to the contralateral normals. So this is what I told. Lift-off test. It is called Gerber's lift-off test for subscapularis. So this test and all will indicate supraspinatus, infraspinatus, teres minor, and subscapularis tendinitis. For tear, rotator cuff or supraspinatus tear, there is one test called drop arm sign. Stand at the back of the patient, make the patient stand, and you can ask the patient to lift the arm. If there is a tear, patient can't lift initially itself after some 10 to 15 degrees. Patient will find difficult to lift the arm and patient will sway towards the opposite side. So what you do, you passively abduct the arm, passively abduct up to 90 degrees. And you ask the patient to hold the arm. You drop, you take the hand. Patient not able to hold. Patient arm also will drop. So that is called drop arm sign. That is because of there is a tear in the rotator cuff. And this is another test called belly press test. This is also for subscapularis. So normally belly, while as the press the belly, your hand should be in the equal, straight. But if there is a subscapularis tear or tendinitis, there is a bend because patient will force their hand and wrist muscle for pressing the belly. So this is called belly press test. So these are the tests you should do to know whether there is a rotator cuff tear or not, rotator cuff injuries, or whether it is a tendinitis to go for a investigation. So after the examination and history will come for us in provisional diagnosis. So next what we will do? After you have come to provisional differential diagnosis, you go for investigation. What investigation you do? Basically, you do the X-ray of the shoulder joint. So X-ray, you should know any fracture is there, any arthritis is there, any acromioclavicular dislocation, arthritis, glenohumeral arthritis, instability. Then if you suspect any rotator cuff tendinitis or tear, the specific main investigation is the MRI of the shoulder joint. What you will check for the MRI of the shoulder joint? How do you know the tear is there is a tear in the ligament? It is you need to check the hyperintensity of the ligaments at now. If there is a hyperintensity, there is a tear is there. Okay, you should always compare to the opposite side of the shoulder if you have doubt. And for adhesive capsulitis, what you will see in the MRI is you should check for the axillary recess. Normally, axillary recess will be there, but if there is a loss of axillary recess, then that is indicative of adhesive capsulitis. Okay, so this will complete your clinical examination, anatomy, and investigation of the shoulder joint. So I hope everything will be clear. Next class, we will see the what are the conditions and what are the treatment for it. Okay. Thank you, students. Have a nice day.